presents to your clinic with this finding, how would you assess him?
So I'll see him in my penile cancer clinic with a cancer nurse specialist, where I'll take a history, examine this patient, and arrange some tests. In my history, I will establish this patient's age, how long he's had this lesion for, whether it's bled in the past. I'll ask about risk factors for penile cancer, such as previous STIs or HPV infection, smoking, phimosis, or previous use of UV radiation treatment. I'll ask about systemic symptoms or symptoms of advanced disease, such as weight loss or any noticeable groin swelling. I'll establish his past medical history, drug history, including anticoagulation status, and allergy status. I'll then examine this patient with a chaperone, a general examination, and abdominal examination, feeling for a palpable bladder. I'll examine the genitalia, inspecting this lesion carefully and also palpating it. From the picture, the foreskin was retractile, so I will visually inspect and feel and palpate this lesion. I will conclude my examination by examining the groin as well for any palpable lymph nodes.
Okay, you mentioned about palpation for a palpable bladder. Is that likely?
Sorry to interfere. Emika, on the background, I think we have your family. So maybe you can switch off your camera if you don't mind.
Okay. Let's take that off. Yeah.
Ayo, when you're projecting the slides, make it full screen, please.
Okay. Yeah, sure.
Yeah.
Thank you.
Okay.
Yeah. So you mentioned about a palpable bladder. Is that likely in this gentleman?
Not necessarily, but it will form part of my urological assessment of this patient, but not necessarily
okay, so,
in penile cancer.
So what are you going to do next with this gentleman?
So I'll explain my concerns of a penile lesion, and I will, with a BOWS consent form, describe the procedure of a penile biopsy, which he requires, explain the risks and benefits of this, and arrange for a penile biopsy to happen.
How are you going to perform a penile biopsy? How do you do it? What's your technique?
So in an appropriately anesthetized patient, duly consented, I'll prep this patients. In my practice, I could either do a punch biopsy or an incisional biopsy with a margin of normal skin as well for good pathological assessment.
Okay. So license sclerosis, what is that and what's its relationship with penile cancer?
Sorry, I missed the question. It was a bit interrupted.
So the biopsy shows that it's lichen sclerosis. What's lichen sclerosis and what's its relationship with penile cancer?
So lichen sclerosis is a chronic inflammatory condition of the penis and foreskin, otherwise called balanitis xerotica obliterans. This condition is a risk factor, or it's a premalignant lesion and can progress to penile cancer.
Is it a premalignant lesion or is it a benign lesion?
It is a benign lesion, but it's a significant risk factor for penile cancer. Sorry.
Okay, so how common is lichen sclerosis?
Not exactly sure how common it is.
Okay, so the patient's really scared now. He wants to know, should he just have his glands removed if it's going to develop into penile cancer? What can reassure him?
So I'll like, if it's not circumcised, then the first step would be to circumcise him. I wouldn't recommend any further treatment. Circumcision in most cases will resolve or at least control this lichen sclerosis.
Mm-hmm. So he's been circumcised a couple of years ago, actually. So what are the other treatment options? He tells you that this redness is really quite sore for him.
So I could prescribe topical steroids like hydrocortisone or betnovate cream, and review him again in 4 weeks' time to see the response to this treatment.
Anything else you could give him?
I don't know. Anything else?
Have you heard of imiquimod?
Yes.
What is it?
So imiquimod is it's a topical treatment which induces or upgrades immunological response to treat skin lesions, usually PEIN.
Okay. How would you, if you were going to give it to a patient, what instructions would you give the patient?
So I'll advise them to apply once a day for 5 days in a week for up to 6 weeks, and then reassess them to see the response after another 6 weeks. Okay.
Are there any side effects?
So side effects include local inflammation, redness, weeping can happen, dryness as well. And I can advise them to use petroleum jelly if this becomes very troublesome or problematic to them.
Okay. You mentioned about circumcision earlier. How would you perform that?
So in an appropriately anesthetized and consented patient, I perform the sleeve technique in my practice. I will mark my incision area, so circumferentially mark the outer layer of the glands, and also perform a dorsal slit and mark the about 0.5 centimeter proximal to the coronal sulcus, dissect out the foreskin and close the wound with absorbable stitches. Before this, I would have given a penile block before this position.
And what would you write on the consent form?
So my consent form, I'll explain the risks of the procedure and the benefits. Risk being risk of infection, bleeding, poor cosmetic outcome, altered sensation on the glans penis, and general anesthetic risks.
Okay, meatal stenosis?
Meatal stenosis as well, yeah.
Okay, you've got a new patient. Let's just go back to that case. You did that really well, actually. I'll just go back. So you can give imiquimod for for benign conditions. I haven't really used it for lichen sclerosis, but the books say that you can. The main thing with lichen sclerosis is it's actually very common in relation to penile cancer, which is very rare. So we don't quite understand the relationship between lichen sclerosis and penile cancer. LS is a benign condition. It is a risk factor for penile cancer, but most cases of LS do not progress to penile cancer. Otherwise, penile cancer would be much more common. So, but we do see it commonly in the pathological specimen of penile cancer associated with the cancer. So that's how I'd explain it. It's a bit of a difficult one to explain because we don't fully understand it. Is that okay? That was the only thing that I caught you up on. Okay. So can you see my screen?
Yes.
So this is a new patient. He's 45. He's come to your clinic. I'd like you to do a focused history and examination on him.
So I'll ask about the duration of this lesion. I'll ask about risk factors for penile cancer, sexual history, history of HPV, smoking history, and also previous treatment with UV treatment. I'll ask about any symptoms of weight loss or any noticeable groin nodes, and then I'll document his past history, as well as any treatments that he's had for this lesion.
Okay. So on exam, so he has no real risk factors, apart from the fact that he has his foreskin. You can't see it in the picture. His glands, when you examine him, is soft. He has no palpable groin nodes, and he's normally fit and well. What would you do next?
So I will arrange for a biopsy of this lesion to rule out any malignancy in that case.
Okay,
I'll
so
my concerns to the patient.
Okay, so the biopsy reveals PIN. What are you going to do next?
So I'll discuss this in MDT and see the patient, and the initial treatments I will recommend topical treatments with either 5-fluorouracil or imiquimod.
Okay, so he comes back to your clinic 6 weeks later. He's no better. It's just as red. What would you do next?
So if I tried 5-fluorouracil initially, I could have another attempt with imiquimod to see if he responds to that, and then reassess him again. Okay,
he comes back. He's no better.
So I'm concerned that topical treatment has failed at this point, and I will explain to the patient that he needs. So that was quite a widespread lesion on his glands. So he will require glands resurfacing.
Okay. How do you perform that? What is glands resurfacing?
The glands resurfacing is a surgical excision of the skin around the glands with the lesion, and also taking a deeper biopsy to ensure that there's no invasion. Following on from that, a split skin graft is used to reconstruct or to cover the excised skin.
Are you doing a glands resurfacing of the whole glands or just half of it?
Because the lesion that you showed was involving half of the penis or of the glands, so I could resurface that area with a good margin of about 5 millimeters, and apply a graft over that.
Okay. What are the other indications for glands resurfacing?
So widespread PEIM is the main indication. I'm not sure of other indications.
Okay, so you've got
maybe PTA, PTA cancer as well. Could be an indication for that.
Yeah. You've got a new patient. This time he's 72. He has long-standing phimosis, and he's noticed a smelly discharge from the penis and a lump under his foreskin. What are the risk factors for penile cancer?
So risk factors for penile cancer include a rise in age. Up to a third of penile cancers happening above 75-year-olds. Smoking, phimosis, BXO, previous UV light exposure, and also poor socioeconomic status.
Anything else?
HPV is the main risk factor, which I should have said earlier.
Okay.
HPV.
So when you examine him, he's got non-retractile foreskin, but you can feel a craggy mass under the foreskin. The glands and the corpora both feel normal, and he has no groin nodes. What are you going to do next? What are you going to do with this chap?
So I'll explain my concerns to him and arrange for him to...
What are your concerns?
So I'm concerned that there is an underlying penile cancer in the phimotic foreskin, so cancer involving the glands. But this needs to be confirmed by performing a dorsal slit and a biopsy of this lesion. if the clinical findings are very suggestive as well, I may also arrange for a local staging of this mass with an MRI penis or an ultrasound scan of the penis.
Okay. So what are the pros and cons of performing a biopsy in this gentleman?
So the pros are that
I'm going to repeat your clinical findings. The corpora felt normal. This is a mass attached to the foreskin.
Oh, okay. So for a foreskin mass, then a radical circumcision will be the preferred option to remove the foreskin and also the mass on the foreskin.
Okay. What are the pros and cons of performing a biopsy, though? The patient would like to know, should he have a biopsy before?
So biopsy will confirm histologically the suspicion of a cancer. It would also tell us the kind of cancer in terms of the characteristics of it, grade, and the histological subtype. The disadvantage, I guess, is that you will be you'll be cutting into a cancer and not really removing it. But I don't think that in clinical practice this has any negative impact in terms of the management of penile cancer.
The main disadvantage is you might delay definitive treatment.
Yeah, okay.
You've got to wait. You're going to do the biopsy, then wait for the results, then discuss MDC, then do a radical circ. That's the main disadvantage. So you mentioned a radical circumcision. How's that different from a standard circumcision?
Standard circumcision, I guess some surgeons may be conservative and err on the side of leaving behind some foreskin, whereas a radical...
That's not a circumcision then.
Okay.
So what's the main difference?
I don't know.
So you take all the preputial skin with a radical circumcision. So it's a cancer operation. You've got to get all that away. So you'll have, when you do a standard circumcision, you'll go about 5 millimeters from the corona is where you'll take that inner prepuce, but you take all of the prepuce with a radical circ. So your radical circumcision reveals G2PT1A, SCC usual type. What are the other subtypes and how does that affect prognosis?
So apart from a usual type, you could have the basaloid, sarcomatoid, condylomatous, warty, verrucous, or papillary. We know that the basaloid and the sarcomatoid are the aggressive subtypes of SCC.
Okay, so this gentleman, what's his risk of inguinal node spread?
So with a G2PT
PT1A.
PT1A, his risk of an inguinal lymph node spread is very low.
How low?
I'll say probably 5%.
Okay. Have you got that data from anywhere?
No, pure guess.
Okay, it's probably higher. It's probably about 20.
Okay.
Probably about 10 to 20% actually.
Okay.
So he's got intermediate risk disease because he's got G2. So how would you manage his groin nodes? So you did mention staging at the beginning. How do you stage this gentleman?
So I'll stage him with a CT thorax abdo-pelvis, and also to stage the groin, I'll do a dynamic sentinel lymph node biopsy.
Is that okay? Okay. Are you going to do anything else before the DSNB?
So you could do an ultrasound groin and an FNAC of any abnormal lymph nodes picked up.
What would you do? What would you do with this gentleman?
Okay, so I'll stage him clinically for palpable or impalpable lymph node.
How are you going to do that?
By examining the patient to see if there's any groin nodes. If I can feel a groin node.
Well, I already told you he has no palpable groin nodes.
So in the absence of a palpable groin node, I will arrange for a sentinel lymph node biopsy.
Okay, so you're going to do a CT and then a DSNB?
Yes.
Okay. How would you perform a DSNB?
So the patients will be injected with technetium 99 labeled nanocolloid around the lesion 2 to 3 hours before the actual biopsy. A gamma camera pictures will be taken to identify the most proximal draining lymph node, which will then need to be biopsied and sent for histological analysis.
So how are you going to do the biopsy? I'm not clear on that.
I will perform an excisional biopsy of that lymph node.
How are you going to do that? Talk me through the steps.
So, incision over the marked area where the lymph node is, dissection, dissection down to the lymph node, and surgical excision of it.
Okay. Why might you get a false negative with this technique?
If there are very infiltrated lymph nodes with tumor, then it's possible that those lymph nodes will not drain normally and may be missed by dynamic sentinel biopsy.
So what might you do before the DSNB to reduce that risk?
An ultrasound groin and fine needle aspiration cytology may improve the sensitivity of.
You always do that?
You could also, not necessarily, but you could also use patent blue dye to improve the sensitivity of sentinel lymph node biopsy.
Okay, I'm going to put you out of your misery, Emeka. It's really important you get this bit right. So for staging, you do a CT, chest, abdo, pelvis. That is only to look for metastatic disease above the groin. Okay. Yeah? First thing. If the patient has impalpable groin nodes, they're very unlikely to have pelvic nodes. So penile cancer, it's always predictable. So you won't have groin nodes on the right and pelvic nodes on the left. So you could argue that you don't need that CT, yeah?
Okay.
Unless you found disease in the groin. But we generally do a staging CT. You do an ultrasound of the groins absolutely every time, yeah?
Okay.
And the ultrasound is looking for any radiologically abnormal lymph nodes in the groin. If the nodes all look normal, then you proceed to a DSNB.
Okay.
If the nodes look abnormal in any way, you would do an FNA. Yeah?
Yeah.
Does that make sense?
Yeah. Thanks.
And the DSNB, the reason that you can get a false negative is if the true sentinel lymph node is packed full of tumor, it won't drain, like you said. And so you'll get a second sort of artificial sentinel node.
Okay.
So you'll get drainage somewhere else, which you might then pick up on your DSNB. and you'll say this patient is negative, whereas actually they are positive. You just haven't done an ultrasound to see it. That's why you always do the ultrasound, because the ultrasound will pick up that lymph node that's stuffed full of tumour. Make sense?
Yeah, thanks.
With regards to the DSNB, sort of got a bit of a mishmash. So on the morning of the procedure, you can either do a 1 day or a 2 day protocol. The patient goes up to nuclear medicine. They're injected proximal to the tumour or where the tumour was by technetium nanocolloid, as you said. They're injected at about 4 points, subdermally, yeah?
Yeah.
They'll then have a lymphoscintigraphy, which will show where that will show drainage in the lymph nodes, and that's where you'll pick up where the sentinel lymph node is.
Okay.
The nuclear medicine technician will then mark where the node is. It'll either be bilateral or unilateral, or it won't be there at all. Yeah?
Yeah.
The patient will then go to theatre, be anaesthetised. You will then inject the penis again, same place with patent blue.
Okay.
And then you'll get your gamma counter, and you want to record that it's high over the area that's been marked, because that reassures you that you're going to make the incision in the right place.
Yeah.
Yeah. You'll then make an incision over that mark or over the maximum count with a gamma counter. It's about 3 to 5 centimeters in the groin crease usually. You're looking for superficial lymph nodes. Yeah?
Yeah.
You'll dissect down, and you may see the patent blue draining and directing you to the lymph nodes. So you'll see blue you'll see blue thread, sort of vein appearance, and that's going to direct you to the lymph node. You'll also use your gamma counter to help you isolate where that lymph node is, because where the lymph node isn't present, the count will be low, and you'll suddenly get close to where the node is, and it'll go really high. Okay. Yeah. And the node will then either be blue or it won't be blue, so hot or cold. And then you excite that gets sent off to path. Does that make sense?
Yes.
You don't need to know it in detail, but you need to know roughly those steps.
Yeah.
Okay. Should we carry on?
Yes, please.
Okay, so for this gentleman, you've got non-visualization on the right, and on the left, it's negative. Have you got that?
Non-visualization on the left and negative.
No. Non-visualization on the right.
Okay.
Negative on the left.
Okay.
Okay, so what are you going to do about the non-visualization?
I don't know. I'm trying to
have a think. What could you do?
So you could do you could do a superficial modified dissection.
Okay.
To see if that is still a diagnostic lymph node dissection, to see if that yields anything.
You could do, yeah. What else might you do? Pretty big operation, but you could do that. What else might you do?
You could do video assisted.
Nope.
Okay. I don't know.
You're overthinking it. You could just repeat the DSNB.
Oh, okay.
A few weeks later, or you could offer the patient surveillance.
Okay.
Or you could offer modified, but it's a bigger incision. So you'd probably towards offering him a repeat DSNB if you wanted to offer him anything at all.
Okay.
Yeah?
May I ask,
Yeah.
what's the yield rate, or if you do a repeat DSMB?
It's pretty low, to be honest. But it is an option. I mean, this guy's got intermediate risk disease. You might say to him, if he had a slightly higher risk disease and I had non-visualization, I'd probably be thinking more about a modified or even a radical. But the exam answer would be a modified if it was high risk. For somebody who's got intermediate or low risk, I'd probably suggest he have a repeat DSMB or surveillance.
Okay.
So what's this gentleman's prognosis and how would you follow him up?
So his prognosis is good, given that we haven't yielded any lymph nodes.
Okay, what's good in penile cancer?
In terms of 5-year survival?
Yeah.
So I'll, for an intermediate risk, I'm not exactly sure the figure, but if I were to guess, I'll say more than 75%.
Yeah, it's probably about 85% upwards for this gentleman. Okay, so you've got a new patient. He's 65, he's come to your clinic. He's got a hard irregular mass on his glands. The mass is about 3 centimeters. It's exophytic with surrounding erythema. The glands feels firm. The corpora feels normal, and he's got no palpable groin nodes. So how are you going to manage him?
So again, history, examination, and arrange for a biopsy and local staging with MRI, and then discussing MDT depending on the histology and the MRI results.
Okay. How would you perform an MRI in a patient?
So I will induce an artificial erection by injecting alprostadil intravenously. 10 micrograms.
Okay, yeah.
And then with erection, perform the MRI scan to visualize the penis.
Okay. Are you going to give the radiologist any instructions about the penis?
So I'll instruct them to strap the penis, if possible, to the belly.
Okay. What sort of MRI are you going to do?
So T2 MRI, T2 weighted images, and
okay. You mentioned about a biopsy. Patient's really not keen on a biopsy. He this lump is really bothering him, and he's starting to get problems with passing urine. The MRI has confirmed that it looks like a glandular tumor, penile cancer.
Yeah.
What surgical option would you offer him?
So I'll offer him a glandsectomy.
Okay. Just a glandsectomy? You're going to reconstruct him or offer that? So
glandsectomy and reconstruction of the glands and a split skin graft.
Okay. So you did mention about the MDT. What are the benefits of a supra-regional management of penile cancer? Why do we do that in the UK?
So because of the numbers of penile cancer per year, so they're not very common cancers. So supra-regional MDT guarantees, one, that you have the numbers to maintain specialist capacity, and also you have the specialist radiologists and specialist pathologists looking at this rare urological cancer.
Okay, what are the disadvantages?
So the disadvantage could be that you have a very long waiting list, or you have, because any referrals come from all the hospitals around the region, so you may potentially have delays in addressing or even managing some of the cancers.
Okay, I wouldn't really agree, to be honest. I suppose it's not an unreasonable assumption. The main advantage is you try and concentrate expertise in one centre when you've got a rare cancer like this, and then you uniform pathways as well with rare cancers. Allows you to often improve the service and also drive research as well. The disadvantage is often these patients may have to travel quite far. So, you know, in the West Midlands, you've got patients coming down from Stoke, and they may be elderly, and they may not want to come because it's too far, or they have difficulty getting to you logistically. That's the main disadvantage, I think.
Okay.
And you also de-skill the local urologist in the management of penile cancer as well when you specialise things that much. But there are more pros than cons. So you mentioned a glandsectomy. How would you perform that, and what are the risks?
So the surgical approach would be excision of the glands down to the corpus spongiosum. Risks include bleeding, infection, damage to the urethra or urethral stenosis. Because this requires skin grafting for reconstruction, you can have graft rejection or graft failure. There's also the risk of erectile dysfunction or altered sensation after the reconstruction.
Why would they get erectile dysfunction?
I don't know. Maybe sensory. The distal nerves could be affected during the surgery. So
are you gonna, when you do your operation, do you go deep or superficial to bucks generally?
So you will go superficial.
And where are the nerves?
They're deep.
Okay.
They're deep, yeah.
So
but I guess the nerve do have endings though, which you'll be removing when you dissect out the glands.
Yeah, you shouldn't really get erectile dysfunction, but you can do. You're right. I was just
sorry. I had a call, so because I'm on my phone, I lost you temporarily. Yeah.
You shouldn't really get erectile dysfunction, but you can do. So have you seen a glandsectomy, Mecca?
1 second, I can't hear you anymore.
Hello?
Can you hear me?
Yeah, can you hear me?
No. Let me get my, just bear with me 1 second, let me get my ear, please.
Okay.
Sorry about that. Can you hear me now?
Yeah, can you hear me?
Yeah, that's better, yeah.
Okay. Yeah. I was saying that you shouldn't really get erectile dysfunction, but you can do. Okay. So have you seen a glandsectomy with me? I can't remember if you came to any of my...
No, I haven't. I've seen a partial penectomy, but not a glandsectomy.
Okay, so what you do, again, you don't need to know this in great detail, but you're going to make a circumcoronal incision. So you're going to make an incision slightly inferior to the coronal sulcus.
Okay.
You go through skin, through dartos, and you're dissecting down onto buccal fascia. Yeah?
Yeah.
Now you tend to dissect the glands off buccal fascia. So you'll find the plane at the corona is where you normally start. You'll find a plane between the spongy tissue of the glands and the corporal tip. So if you stay on bucks, you just dissect all the way round slowly in that plane, and you'll end up with the glands being lifted up, and at the end you'll just have the urethra, and then you'll cut at that point. Yeah, okay. Does that roughly make sense?
Yeah.
So you'll end up with the urethra and the corporal tips.
Yeah.
You can, at that point, you will either just suture, you'll spatulate the urethra. If you're not reconstructing, you spatulate ventrally, and then you do a full thickness on the urethra and onto the penile shaft skin, and you bring everything together. Yeah, that's if you're not reconstructing. If you're reconstructing, you will then put tacking stitches all the way around on the shaft skin, so that you'll suture the shaft skin onto the corporal bodies all the way around about 2 centimeters from the corporal tips.
Yep.
You'll then take a split skin graft from the upper thigh, generally about 14 or 16 1/1000th of an inch. That's the thickness. And the measurement length and width depends on the length and width of what's left behind after you have sutured the shaft skin to the corporal bodies. Make sense? So you'll measure around, and you'll measure from where the shaft skin's been approximated to the top.
Yeah.
And then those dimensions are what you'll measure on the thigh. You'll take a split skin graft using an air dermatome.
Okay.
And then you'll just suture that to the penis. And you'll either, I don't tend to spatulate the urethra when I reconstruct, but I will if it looks like it's a narrow lumen. So if it looks like it's wide open, then you don't need to spatulate for a glandectomy. If it looks like it's narrow, then I'll spatulate, and then you'll suture the lower limit of the graft onto the shaft at the bottom, and then the upper bit of the graft you'll suture that to the urethra.
Okay.
And then you'll put a tie-over dressing of some sort, or you'll put quilting sutures in. Okay. So I generally put a tie-over dressing, which is just gelinette, and you suture it through the graft with big sutures like Proline or PDS, and that stays on for usually 10 days. And the catheter stays in for the same period of time. That's it, more or less.
Yeah.
Make sense?
Yeah, I guess I'll see a lot in January when I come over.
Yeah, you will. I will. It's worth Googling it. There's a paper. It's very old now by Ari Parnham in European Urology.
Okay.
And they did a really nice video of a glandectomy there.
Yeah.
Now, occasionally, if the tumor looks like it's going deep to bucks, you might still be able to get away with a glandectomy, but you'll then dissect glands off by going deep to bucks. But usually you go superficial to bucks to get the glands off.
Yeah. Would you always do a base biopsy and maybe send for frozen section when you do a glandectomy, or would you be happy with a macroscopic removal?
So it depends on what it looks like. I don't have those facilities to do frozen sections. Okay. It's not a bad idea. We never used to do that in London for the glandectomy. So I will tend to take margins from the corpora and from the urethra. So I'll take a small margin from those, send those separately as my margins to make sure that I'm clear.
Okay.
Yeah.
Thanks.
You could do frozen sections if you've got that facility. Yeah. Okay, so do you know of any alternatives to a glandectomy if only a portion of the glands is involved? And are there any disadvantages?
So you could do a wide local excision.
Yeah, you could do.
If only a portion of it is involved. And I guess I'm not sure if you have a higher recurrence rate with that compared to a glandectomy or not.
Yeah, you do. That's the main disadvantage, that you might have positive margins. Your margins might be quite close. You could also do a partial glandectomy. Personally, I don't think the cosmesis is as nice with a partial glandectomy because you end up with the glands looking slightly lopsided. But that is an option. We briefly talked about this. What's the role of imaging in penile cancer for the penis and the groin? Is there a role?
There is a role for radiological staging of the penis as well as the groin. MRI penis were mentioned. You could also use ultrasound, Doppler ultrasound of the penis.
So what are you looking for when you scan the penis?
So you're looking to see if this cancer invades the corpus or the corpora cavernosum, and it could also tell you invasion into the spongiosum as well.
Anything else?
If you scan the groin, if you scan the pelvis as well, then that will give you a lymph node staging as well. If there's any groin lymph node or pelvic lymph node involvement.
Okay. Anything else you're looking for in the penis when you scan?
Can't think of anything else.
See, you're also looking for skip lesions.
Okay.
It's a very poor prognostic sign if they've got skip lesions. And don't forget, some of these patients will be overweight. They might have a buried penis. Might be very difficult to assess the penis clinically as well. So those are the real reasons why you want to image the patient. So you're looking for metastatic disease.
Okay.
We talked about you using ultrasound to scan the groins. What are the ultrasound characteristics of an abnormal groin node in penile cancer?
So this would include an abnormal hilum of the lymph node.
Abnormal hilum. I think you were about to say it actually.
What do I mean by abnormal hilum? I don't know the radiological features of an abnormal hilum, but...
Okay, just tell me just carry on as you were before.
Okay, so I would also be looking for the shape of the lymph node. So a normal lymph node will be elliptical, whereas an abnormal lymph node will lose this elliptical shape and may be irregular as well. And the size as well of the lymph node can be measured with ultrasound.
What size would be abnormal?
So in the groin, above 8 millimeters.
Where does that data come from?
I believe.
So penile cancer is really unusual. There is no size criteria, really.
Oh, right, okay.
Tells you if it's abnormal or not. So it's all about its morphology. Okay. So you're looking for loss of the fatty hilum. I think you were about to say it and I interrupted you, so sorry. And then the lymph node will go from being elliptical, as you said, to round. You'll get narrowing in the center, and it becomes, you know, the hourglass that we talk about.
Yeah.
If you turn it on its side, that's sort of what an abnormal lymph node will start to look like. So at the peripheries, it will look fatter and then it will look narrow in the middle.
Okay.
And then you look at the ratio between the short and the long axis as well. If that's above 2, that's another marker that it's abnormal. And then, you know, things like necrosis as well might all suggest that it's an abnormal lymph node. So the pathology on this gentleman reveals SCC, just involving the glands, but he's got positive margins. What's the TNM staging here?
So this would be in keeping with a T2. MX.
Okay. What are you going to do about his positive margin?
So that will need so he needs to come back for a reset. Well, will I say a distal penectomy now? If it's got positive margins.
What sort of penectomy are you going to do?
A partial.
Okay.
Partial distal penectomy.
Okay, so are there any alternatives to that? The patient's very worried about losing any more length. He doesn't want to lose any more of his penis.
Could you do a repeat resurfacing and take more?
Is that called a resurfacing? What's a resurfacing?
No, you've done a resurfacing already. So, I don't know what it's called.
So you could just survey him as well.
Okay.
But you'd have to warn him that, you know, there's a risk that he's going to recur. And it needs to be a patient who's reliable. So they're going to self-examine and they're going to tell you if something appears sooner rather than later. So that's one option. The other option is that you go back in and you take a bit more. So you'd end up doing a distal corporectomy probably, which is essentially a partial, but, you know, a very, not a generous partial, you know, so you're going to leave them with as much length as possible still. You just end up taking, if it's just at the margins, you would just take, you know, you just nibble off the distal tips of the corpora and hope that, you know, you've got all of it at that point.
Okay.
Yeah. What are the TNM staging classifications for penile cancer? Can you tell me?
Yeah. So TIS, PEIN, TA, non-invasive cancer. T1 could be T1A, T1B, when it invades the lamina propria. T1A is where there is no perineural lymphovascular or a grade 1 and 2. T1B is where there is perineural lymphovascular or higher grade, so grade 3 disease. T2 is involvement of corpus spongiosum plus or minus urethra. T3, corpora cavernosa plus or minus urethra. T4 will be adjacent tissues like the scrotum, prostate, or bone. End stage will be N1, single or 1 or 2 lymph nodes unilateral with no extranodal extension. N2 will be 3 or more on one side or any number of bilateral lymph nodes with no extranodal extension. N3 will be extranodal extension of any number or pelvic lymph node involvement. and M0 no metastasis, M1 metastasis.
Okay. So have you heard of penile preserving surgery?
Yes.
What is it and what's its purpose?
So penile preserving surgery avoids performing a penectomy or partial penectomy, and the purpose is to preserve as much penile length to, one, help the patients pass urine into a toilet, and possibly preserve sexual function for penetrative intercourse, and also avoid the psychological trauma or impact of emasculination.
Mm-hmm. Okay. What are the disadvantages?
So the disadvantage will be a higher risk of local recurrence compared to penectomy.
Okay. Does that affect prognosis, local recurrence?
No.
Okay. Where does that data come from? Are you sure?
I chose the wrong answer, so...
No, you didn't. You're actually right. No, you're right. It doesn't actually affect prognosis, local recurrence. Most people go the other way. So how much of a margin do you need for clearance in penile cancer?
So 5 millimeter margin, 3 to 5 millimeter.
Okay. Is there any evidence for that?
I think the EAU guideline divides it into the risk category, so low, intermediate, and high. And so when you've got the low risk, then 3 millimeter margin may be appropriate. Intermediate, 5.
How do you know if you've got low risk if you haven't biopsied them?
So you would have biopsied first to categorize.
You always biopsy penile cancer?
No, not always.
So how do you risk stratify them if you haven't biopsied them?
I think generally a safe margin is 5 millimeters margin.
Yeah. Where does the evidence for that come from? Do you know?
No.
Okay. So there have been a couple of papers. They're all old now. The British one. You don't need to know papers for the exam. If they're asking you about papers, you've passed. So it's Minas et al. And they looked at different margins for penile cancer. And there was no, and they found that I think less than, because it used to be 2 centimeter margin, which on a penis is a big margin. You take their cancer away and then you take 2 centimeters more. So I think it was less than 10 mils. There was no oncological disadvantage, but there is an increased risk of recurrence if sorry, I'm getting confused. There was no oncological disadvantage with a smaller margin. So the EAU, I think now say 3 to 5 millimeters is probably reasonable. But in reality, you just want a clear margin, really. So, you try and leave them with as much of their penis as possible. So what are you going to do next for this chap? So don't forget, he's T2, clinical N0, and his ultrasound was normal.
So with a T2 tumor and a normal ultrasound, we will proceed to a dynamic sentinel node biopsy.
Okay, good. So his DSNB is positive on the left and it's negative on the right. What are you going to do next?
So radical groin dissection on the right.
Okay, I'm going to repeat that. So it's positive on the left.
Oh, sorry. So radical on the left.
Negative on the right. Okay. So what are the complications of a radical groin dissection?
So complications include immediate complications such as vascular damage and bleeding, and later complications such as lymphocele, lymphedema, lymphoria. There's also risk of flap necrosis and altered of patchy sensation around the skin of the thigh.
Anything else? What's the overall morbidity with a lymph node dissection? Do you know?
It's about 30 to 50%.
Yeah, it's probably about that. It's probably close to 50.
Okay.
Mean people will say it's 100%. I've never seen a patient have that operation or have some sort of problem, to be honest. Okay, so you've done the radical groin dissection. It reveals one node positive out of 12 with extranodal spread. What's his T&M staging?
So that'll be T2, N3, MX.
Okay, what are you going to do next for this chap?
So this chap needs a pelvic lymphadenectomy on the ipsilateral side.
Okay, so what are the other indications for performing a pelvic node dissection in penile cancer?
So if the radical lymph node dissection yields 2 or more positive lymph nodes on that side, then the patient will require a radical pelvic lymph node dissection.
Anything else?
Or if there's, from the outset, evidence of pelvic lymph nodes on staging scan.
Yeah. Okay, so his pelvic node dissection is negative. What's his T&M stage?
Still T2 and 3. MX, M0.
Yeah.
Because we've done a CT, yeah.
Okay, how are you going to manage this chap?
So he will require, given the N3 status, he will need adjuvant chemo and very careful follow-up post-operatively as well.
Okay. Why are you giving him adjuvant chemo?
Because he has M3 disease, so lymph node with extranodal extension would be an indication for adjuvant chemo.
So you're going to irradiate his groin or his pelvis or both?
There is a role for radiotherapy in patients with extranodal spread. So I'll irradiate the groin, not necessarily the pelvis, but the groin. Okay,
so you're not quite right. So you would give him the reason why. So the extranodal spread in the groin nodes is why you would offer him a pelvic node dissection, because you worried that he's got micrometastases. You probably would irradiate you'd probably offer him radiotherapy to the groin, actually, with the extranodal spread, you're right, and probably adjuvant chemo as well. Okay, so do you know what regime they use?
So a combination of cisplatin and a taxane and 5-fluorouracil, 3 to 4 cycles of that.
Yeah, I think so. Have you heard of a modified groin dissection?
Different from a superficial?
I don't know, you tell me.
I believe that a modified dissection is halfway between a radical groin dissection and a superficial dissection. I think the difference.
I'm not sure what a superficial dissection is, Emeka.
superficial modified groin dissection,
Okay.
or is it modified superficial inguinal dissection? I think it's called, isn't it?
I generally just call it a modified.
Okay. So
you could call it a modified superficial, I guess, if you want. So when would you do that? When would you do a modified groin dissection?
So it's more of a diagnostic as well for staging. If you don't have the facilities for instance, a dynamic sentinel lymph node biopsy, then you could do a modified dissection to see if there's any positive nodes, of which if there is, then you would then move on to a radical dissection.
Okay. And how would you do a modified?
So the incision is a smaller incision compared to a radical, and the lymph nodes of interest are the superficial group of inguinal lymph nodes, which will be dissected and sent for histology.
So what are your boundaries?
So it will be removal of the inferior medial and inferior lateral superficial groups and superior medial as well.
Okay, you haven't answered my question. What are your boundaries for a modified?
I don't know. Not as wide as the femoral triangle, but I'm not sure exactly what the boundaries are.
So it's pretty much the same, but you just go your lateral boundary is the femoral artery.
Oh, right, okay.
So it's a very similar operation, slightly reduced morbidity because the incision's smaller. What are the risks of the procedure?
Risk of infection, risk of bleeding, again, risk of lymphedema or lymphuria, but less than you will get for a radical lymph node dissection.
So what's the role of frozen section with modified?
So if you send for a frozen section and that confirms presence of tumor, then you can convert that to a radical groin dissection at the same sitting. Yeah,
absolutely. Okay, so you've got another patient. I think this is your last one. He's 45. He presents with phimosis, and he's got a firm fungating mass involving the corpora. He's got a left groin mass, which is discharging, and he's got a palpable firm node in the right groin. What's his clinical staging?
So this would be at least a clinical T3, N3 tumor.
Yeah. What's his M staging?
So it's invaded the skin and it's
no, I haven't said that.
Gated.
It's fungating. So he's MX.
MX. Yeah, we haven't staged it.
Yeah, what are you going to do with this guy?
So he needs to be discussed at MDT. He needs a full staging scan, CT thorax abdo-pelvis. I suspect that the MDT will recommend neoadjuvant chemo.
Why?
To downstage his groin nodes, for instance, to allow a possible excision of that. But I guess in this case, it's probably palliative if it's already fungating.
He's 45, Emeka. He's 45. Okay, so what information do you want from his imaging?
So I want to know if he's got any distant mets. I want to know about his pelvic lymph node status as well as his groin lymph node status. And I want to know about the extent of penile involvement in the cancer.
Okay. So what do you, if the patient really doesn't want, he doesn't want chemo or radiotherapy, he wants surgery. So what could you do for this chap? What are the possible options surgically?
So his possible options will include a partial penectomy, or depending on the extent of the involvement of a penis, or a penectomy. And for the groin lymph, for the fungating groin nodes, excision of those and creation of a flap to cover the defect.
Okay. So actually, you've done an FNA of those groin masses, and it's positive, and his imaging shows that he's got bilateral pelvic lymph nodes as well that are involved. What are your concerns with this gentleman if you're thinking about tackling surgery for him?
So this is extensive nodal disease for him, with also fungating groin lymph nodes. This patient doesn't want chemotherapy, you said. However, he will require a groin node dissection, as well as a pelvic lymph node dissection. We will be leaving a defect that will require a flap for closure, and the flaps that we could use could be a tensor fasciae lata or rectus abdominis flap. But if you're performing a pelvic lymph node dissection, then your subumbilical midline incision potentially could make it difficult to use a rectus graft.
So you're slightly overthinking it, and probably led you down that way. So for this chap, you're right. When you started off, he's probably going to be palliative. He's going to be and I think you would not be wrong to say that right at the start. You know, this is going to be a really challenging case because he's probably going to be palliative. He's got high volume of cancer that probably isn't going to be curable. When you're discussing about the MDT, if you're contemplating surgery, you want to know if those things are going to come out. And what have you done any groin node dissection with KJ or I?
No.
So the lymph nodes.
I've done the gynaes, but not urology.
The lymph nodes are always stuck on the femoral vessels, the femoral vein in particular. That's where they're stuck. So you want to know if it's infiltrating the wall of the femoral vein. Is there a plane that you can get this thing out? I wouldn't do this sort of case without vascular and plastics.
Okay.
You know? Because if you run into trouble, it's probably going to be at the groin, and it's going to be the femoral vein. You're going to rip a hole in it. So you don't want to start off at all. If the radiologist says there's no plane, you're never going to get this thing out. So that's the first thing you want to know. And then, you want to know about METs as well. Obviously, they're very difficult patients to manage once they start to fungate their groin nodes. It's very difficult to manage them surgically, and it's very difficult to manage them oncologically, and it's very difficult to manage them with nursing care. There's very little you can do. It just continues to fungate and discharge. Your oncologist is very unlikely to give them radiotherapy or chemotherapy if they've got an open wound that's discharging. Because they won't make them better. They'll make them worse. Now you could try to, if it wasn't discharging, or you can persuade your oncologist, they could give them some radiotherapy and some chemo to try and downstage them. The disadvantage with that is that it's sort of 50-50 whether they'll respond to chemotherapy. In penile cancer is terrible. So if they don't respond, they'll progress. And if they progress, you'll lose the opportunity to cure them or to surgically palliate them in some way. If you treat them surgically first, and you can get them off the table without killing them, they may never get well enough to have chemoradiotherapy afterwards, in which case they'll then die anyway. And if you're thinking about surgery in this sort of case, he's going to be on the table for a very long time. So he's got to be fit, because it will take you. He's probably going to end up with a subtotal penectomy.
Yeah.
I haven't told you his penile staging, but he'll probably end up, with that sort of disease. His penis is probably all rotten as well. So you will spend an hour and a half, 2 hours doing his penis. You'll then spend about an hour and a half on each groin, then, maybe an hour on his pelvic nodes, or maybe an hour or 2 hours on that. So you're looking at maybe 6-8 hours on the operating table for a palliative operation that he may not survive. So for a case like this, you would want lots of people helping. You discuss it at the MDT with the oncologist. You definitely discuss it with plastics and vascular as well before you get involved. And it's a lose-lose situation.
Exactly, because then he's got poor prognosis disease. So I really understand why go through this extensive surgery if he's probably got a few years, a lot to leave, really.
He's not going to live. He's not going to live 6 months. This guy, unfortunately. But in these sort of cases, sometimes you may do a bit of surgery because you're trying to stop them having a miserable death.
Okay.
You're not going to cure this guy, but it may mean that instead of him dying with a fungating bilateral groin, that he dies with maybe one fungating groin. And that might be, if you can clear just his groin nodes, that might, and sort out his penis, that might be enough, because his pelvic nodes won't fungate. That's not what's going to make his death miserable. It's the fungating, it smells horrible, smells like rotting flesh. They've got their family, they're dying, and there isn't a lot you can do for them when it gets to that stage. So that's why sometimes you might operate, or you might try and persuade the oncologist to give them something to help. So this is a gift if you get a question like this, because you can really talk around all the different options, the pros and cons, and how it's difficult. And you can't fail unless you say, this guy needs, surgery. I'm going to do everything on my own. If you get this sort of scenario, you just have to be reasonable and talk through it and know the sort of pros and cons of everything. Everything is a con for this guy. He's going to die, unfortunately. Does that make sense?
Yeah, thanks. That's very helpful.
Okay, so let's say we're going to do a pelvic node dissection. Do you know what the boundaries are for penile cancer?
So
you should do. Definitely done this.
External, so you're taking the external iliac group of lymph nodes with the lateral boundary being the genitofemoral nerve. You're also taking the obturator group, I believe.
Yeah. So what
do you think? Do you don't go for the internal iliac? Do you? I don't think you do for penile cancer.
No, it's just the external iliac.
Yeah.
Okay, so this guy's final pathology, you've managed to operate on him. He's got his G3, PC2A, N3. His right groin, he's got 4 out of 10 nodes positive with extracapsular spread. His left groin, 9 out of 10 with extensive extracapsular spread. He's got bilateral positive nodes from his pelvis with extracapsular spread. What might you offer him next?
Forgive me, it's screwed basically. Forgive my language, but you can offer him palliative radiotherapy,
Chemorad
to the pelvis and groin.
Yeah.
Palliative.
Yeah, absolutely. He's not going to have got that far though. That's my last scenario for penile cancer, Mecca.
Thank you.
I thought you did really well, actually. Just a few tweaks. You've got to speed up the history and examination. I always say you need to get that out in under a minute. You're not getting any points for taking a history. They don't really care. They expect that you should be able to do that well. So you're getting the points subsequently. So you've got to get past that really quickly. So it's got to be really snazzy. So what I would say is you want information about the lesion, how long it's been there, is it causing any problems like discharge, difficulty with waterworks, has he had anything like that before? Then I'd ask him about risk factors, and just very quickly, I might not even say what the risk factors are unless they want me to know. They can bring me back and specifically ask me what those are. I'd ask about risk factors, and then you want to know about his comorbidities, drug history, who's at home with him, his performance status, and then you're going to examine him. You can talk about examining the abdomen. It's not wrong, but the first thing you want to know is, does he have a foreskin? Is it contractile or not? Where is the lesion? How many are there? How big is it? What's the depth of invasion? So is it just the foreskin? Is it involving the glands? Is it involving the corpora cavernosum? Is it involving the urethra? How far down the penis does it go? And then I'm going to palpate his groins. I'm looking for any palpable lymph nodes. And that's pretty much it. It's a focused history and examination. You should be able to get that out less than a minute. So, and that's just practice, Mecca.
Yeah.
You didn't. I think you didn't say anything that was terribly wrong. There were just a few tweaks, I thought. I've got some slides that I'll share in the group. Would it be helpful to share it now or later? So it's just some notes on andrology and penile stuff that I shared with you guys.
If you share it, then we will all have access to it, and we can always look at it in our own time.
Okay,
fine. It'll be helpful, to share it.
Okay, fine. I'll do that then. I'll share it in the group. It's in my Dropbox, so I'll just share it that way. It's not everything, but it's just the things that you might forget, and just like an aid memoir for most things. That'll be good. Yeah. Okay, cool. I will see you on Saturday then. Yeah. That's okay. I was thinking, I've got loads of time on Saturday. Why don't I'll do penile cancer again with Piyush, but you do fertility. Yeah. I can spend half the time with him and then the other half with you.
That's fine. So
it's not sort of boring for you.
Yeah, absolutely fine. Yeah.
Okay.
Thank you.
Cool.
See you on Saturday.
See you on Saturday. Take care.
Bye-bye. Bye.